There's a couple of ways to try to risk stratify in mantle cell lymphoma. So there's something called the MIPI, which is the mantle cell IPI, and that uses 4 clinical factors: age, performance status, white blood cell count, and LDH. Our particular patient is high risk if you calculate his MIPI score. There's actually an online tool that I would suggest people use if you want to generate the MIPI score. It's not something that you can do by hand because it's kind of a complicated mathematical formula, but if you just plug the numbers into the online formula, it'll give you the MIPI risk score very easily, and that's what I did for this patient. You can also do some biologic risk stratification. The best way to do that is to try to get an estimate of the proliferation. So you can do a Ki-67, and we were not provided the Ki-67 stain in this particular case. In mantle cell, anything over 30% is considered highly proliferative. Anything below 10% is low proliferation, and between 10 and 30 is intermediate proliferation. So we don't know that in this case, but those would be the 2 most common ways to risk stratify in mantle cell lymphoma. Our patient will be high risk by the MIPI score. We don't know the Ki-67 to give him a biologic risk stratification. I would say risk stratification is moderately important. Certainly if people have high risk, their prognosis is not as good as patients who have low risk. But it turns out that one of the most important factors for determining risk is age. And many older patients turn out to be high risk, and many younger patients turn out to be low risk. So what do you do with that? For many older patients who are high risk, intensifying their therapy is not always a good option because they're older, they're more frail, and they can't take more intensive treatments. So I think the risk stratification is very helpful for trying to analyze data from single-arm studies. It helps you get a sense of the patient population. And the other place that I like to apply risk stratification is when I have patients who are really borderline, someone between the age of 60 and 65, and I'm trying to decide if I'm going to pursue an intensive treatment strategy or a non-intensive treatment strategy. And a lot of times I'll use the risk stratification to help me decide. And if I have a patient in that age group and they have a high risk, I'll go in more intensive, and if they're low risk, I might go less intensive for their treatment strategy. But for our patient, the one we have here, at age 72, I don't think an intensive treatment strategy is frankly appropriate for him. When I look at that data, the outcomes for intensive strategies in older patients does not look that much better than non-intensive treatment strategies, and I don't think it justifies all the toxicity that intensive treatment strategies bring into play. So in this case, the risk stratification is not going to change my management decision.